Hi, Gummies. How are you doing today? As you can see, I have another guest with me, and her name is Alecia Johnson, and she's going to talk to us today about her career in the nursing field. Did you want to introduce yourself?
Sure. Hi, Gummies. My name is Alecia Johnson. I am a registered nurse at two hospitals in the Baltimore, Maryland area. I've been a nurse for 28 years. I worked for my first 13 years of my career. I worked in an ICU in a downtown Baltimore hospital. Thoroughly enjoyed working in the intensive care unit. And I had an injury actually to my back. And I was like, okay, well, I enjoy taking care of patients in the intensive care unit, but what else am I good at? And I was always a go-to person to put IVs in patients, whether it's the most critical patients or, the more stable patients. I was always the go-to nurse to help the nurses establish IV access in their patients. So I became an IV nurse, and then I went for further education and became a vascular access specialist. And that's what I do for the most part, is a vascular access nursing.
Before we dive into what vascular access nurse is, why did you decide to become a nurse? What made you go into that field?
Okay. Actually, as a young girl, I wanted to be a veterinarian. So I always had the mindset of taking care of a species, I should say, start with. I loved animals, I still do, so I wanted to be a veterinarian. And probably around in middle school, I was informed, or I learned of how many years a veterinarian would have to go to school. And I was like, that's probably not going to be good for me. So I had other ideas of what else I wanted to become. And once I was getting ready to graduate from high school, when I went to college, I was like, okay, I still enjoy taking care of. That's my heart. I enjoy taking care of, but I don't want to go to school that long to become a doctor and then specialize in veterinarian medicine. So I was like, I took some health classes, and I was like, I enjoy this. Let me focus on helping people, not animals, but people. So I looked into the nursing curriculum, and I was already taking nursing classes, like prerequisite classes, like health classes. So my mindset stirred toward helping people. So that's how I became a nurse.
I guess I never really thought about that for veterinarians. You just go through the regular process of becoming a doctor, and then there's additional school to become a veterinarian. Okay.
Yes.
Wow.
So it's the 4 to 8 years, whatever it is, for the doctor, and then you go into your specialty, which then you have to go be a resident and start almost, it seemed to me, from the beginning. But yeah, you go through many, many years of being a veterinarian, go to veterinarian school.
Interesting.
Okay. It's a process. So I still love animals. We have animals in the house here, but I take care of people now. So
how many animals do you have?
Right now we have 2 dogs and a guinea pig who does not want to go anywhere. She's probably about 7 years old. Yeah, so she's been well taken care of. She's been well kept. At one point we had fish and 2 guinea pigs and 2 dogs and a cat, but yeah, things have changed. Yeah.
Okay. So tell us about the vascular access nurse. What exactly is that?
A vascular access nurse is one who has special training when or in establishing vascular access for a patient. So it can be as simple, and when I say simple, the task is simple, but there's challenges in it also. It can be as simple as putting an IV in someone, or as challenging, and which I love, putting in a midline or a PICC line, or a peripherally inserted central catheter, which is a catheter. It's still an IV access, but it's a sterile procedure actually done by skilled nurses at bedside or in an intervention radiology department in their, in a sterile setting. But it's a catheter that can be placed in more than likely the upper arm, and it's threaded into a vein actually right above the heart. So it's a pretty invasive procedure. I enjoy it.
Wow. Now, the port, is that like so that people can get like dialysis, or is that something for cancer patients when they get their chemo, that type of port?
Now, they're all, which you just named, they're all central lines, which basically means the tip of the catheter comes to it, or it terminates in the large vessel prior to the heart, which is your superior vena cava, right prior to the heart. So they're all central lines, but they all have a different purpose. So for your dialysis catheter, which is a central line, that's for dialysis. The portacath, which is an implanted port, it sits, actually can be placed anywhere like upper arm or thigh, but most likely it's placed in the upper chest, and that's a portacath, and that's for your chemo patients or your patients who have poor vasculature of their arms, and that they will get a port for vascular access. We maintain those too. So we do not insert the portacath, the doctors do that, but we troubleshoot, we maintain, we access support, we de-access supports when they're needed in the hospitals.
So when you put those ports in, is it just to help the flow of the blood, or exactly what is that for?
My primary task when I am given a case is to put a midline or a PICC line in. Okay, so they're both vascular access devices. They serve a different purpose. The midline is not a central line. It stops short of your going into your chest, actually, but it's under a sterile procedure. So that, along with the PICC line, which is a central line, it's not called a port. That's something a little bit different, but a PICC line, which is a peripherally inserted central catheter, is a catheter. It's another type of vascular access device. And really those two, the midline and the PICC line, are chosen depending on the type of medication that the patient's on. So depending on what the doctor has ordered, what antibiotic the doctor has ordered, will determine which line we put in. The PICC line is more invasive than the midline, but we, as our vascular access nurses, we do that. Both are under sterile procedure.
Now, when you do it under sterile conditions, do you have to, the patient isn't asleep or anything like that, right? There's no anesthesia involved?
For the midline and the PICC lines, we do local anesthesia or anesthetic. So it's actually, it's an injection of lidocaine that we use most of the time. So we do inform the patient that we cannot put you to sleep, because by the time you go to sleep, we'll probably be done the procedure. But we do give local anesthetic, yes.
So you mentioned earlier that you go to 2 hospitals. You work at 2 hospitals. So is it certain days you go to the hospitals? Is it half days? How does that work?
At one hospital, I work full-time. I'm a full-time nurse at one hospital. And the other hospital, I am a PRN staff nurse, which is when needed. When they have a shortage, I'll go there. So I may pick up a shift at my PRN position maybe 1 to 4 times a month. My full-time position is a full-time position. That's my second life. I'm there a lot.
So out of the areas that you worked in, which one do you like best? I hear you speaking about the ICU very fondly. You sound like you enjoy doing the vascular access, but out of the areas that you worked in, which areas did you enjoy working in?
Both. They're both different. They're both bedside nursing. ICU, I enjoy because there are patients who, if you get to the ICU, more than likely you're in a situation where you can't take care of yourself. You know, you're laying there, you are hooked up to monitors, which we have to continuously assess, monitor to make sure the patient stays stable. They're on drips. The intensity of ICU, I miss. I enjoy the intensity of it. I enjoy the bedside care that was given. You know, you know, it's funny how in nursing, depending on what area of nursing you are, we as nurses know the personality that goes with it. You know, the personality that the ED nurse has, or the psych nurse has, or the med surge has. ICU, they have their own personality. And, you know, yeah, that's my, you know, you don't want anyone touching your stuff. Your stuff is laid out in a certain, you know, way. You're really anal, you know, type A kind of, sort of. But the intensity of it, I do like and enjoy and miss, especially when there's a code blue going on. You know, it's just, the intensity level is so high. Whereas in vascular access nursing, I don't typically have a set team of patients for that one day. I'm seeing all the patients in the hospital if there's a need. So, you know, putting in these lines that I put in, there's some challenge to it, and I enjoy challenges. So it stimulates me to that degree, you know, to keep me satisfied in that area too. So they're both different. They both kind of stimulate me in a different way. But right now, as a vascular access nurse, I enjoy what I do.
Okay. So do you have any plans of moving to another area, or you think you're good, this is where you'll be for a while?
This is where I would probably be for a while. I've been doing it for a while. I'm good at it. I thrive off of challenges. But for right now, this is where I am enjoying what I do. I enjoy helping nurses that are coming up underneath me, showing them how to do it. You know, being a preceptor. Being a lead IV nurse on my team, because I am kind of like the go-to person. So I still am enjoying that right now. So I'll probably be doing this for a little bit more.
So, you know, I have to ask about the whole corona. How has that changed the atmosphere in your field?
Okay, well, we're still having to deal with patients. I have taken care of COVID patients who have been positive of COVID. So I am in those rooms. You think things through more in depth. I think I can only speak for myself. So if I'm going into a patient's room and I know I have to be in there for an extended period of time, you know, they tell us, make sure you bring everything in there that you need so you don't have to go out. You're clustering your care, which means if the doctor's ordering A, B, and C, you make sure you have your stuff for A, B, and C. And if you're thinking that you might need that D, you bring that in there too. You know, we're asking the doctors to order 1, 2, 3, which you know that patient needs, you know, and an hour later, don't order 4. You know, you got to be on point and order all that, because what we're trying to do is minimize the exposure to ourselves. We're being exposed anyways, but we want to minimize how many times we have to go into that patient's room. Okay. So yes, I am doing patient care. I'm in the rooms with the patients who are rule outs, or who are what we call PUI, you know, patient under investigation, or are positive patients. I'm gowning up and masking and wearing my N95 with the face shield. I'm doing all that and being mindful of coming home to my babies and making sure I'm not bringing home anything to them. So, you know, you're just slowing down everything. You're thinking through what you have to do, you know, while I'm in the patient's room. If I have to do this, I'm thinking, okay, so if I do this, I can't have this touch that. I'm thinking through everything. So it's a constant, you're just taking care of yourself. That's your mindset. Even though you're taking care of that patient, you're still there too.
Right.
So you're thinking through everything. Everything's just intense. Everything's heightened in the hospitals right now.
Yeah. Do you have fellow nurses that have tested positive for the virus?
I do not personally. I have heard of some doctors who have tested positive in other hospitals.
Okay.
In our hospital, I have not heard of, well, then again, the hospital that I work full-time in, I haven't heard of anyone testing positive, any employee. The hospital that I work PRN, yes, there are a couple of providers who have tested positive.
Wow. Why do you think that is? Did you just think that your hospital that you work full-time is taking the extra precautions to make sure that their employees are protected? And
I think both hospitals are doing a good job now. That's another subject that we can get into at the very beginning. At the very beginning, when it's all broke out, we weren't happy as nurses. But we can go back to that. But from my understanding, the two providers that came back positive at the other hospital, they are actually had gone up to New York for a convention and then came back.
Wow.
That's what I heard.
Yeah.
So they had to, of course, not being in the hospital, they had to self-quarantine, and, I'm sure they're better because that was about 3 weeks ago.
When was the hospital placed on more awareness? Did your timeline at the hospital kind of match the timeline of the media reporting it to us non-hospital workers? Or how does, what did you notice in the reporting as far as the care as well?
The timeline was pretty close.
Mm-hmm.
The timeline of certain personal protective equipment and what we should be wearing to protect ourselves did not come in line with everything else. At the beginning, we were told, okay, masks, surgical masks, not the N95s at first, within a particular hospital, one of the hospitals I was working at, so we wore the gloves, the gown, and a face mask. And then we started hearing words of, the exposure of it, through the nose, mouth, and at that point, it wasn't quite the eyes yet. So we weren't, wearing the face mask. And then they introduced the goggles, and then it was just the regular surgical mask with the face shield to protect your face or your eyes. And then we were like, we need these N95s. So then the N95s started coming, and it was just staggered. It wasn't what we saw on the news. Everyone wearing the face shields and the N95. It wasn't all that, and the hair coverings. And when we asked for the hair coverings, they were like, no, it's not part of the CDC recommendation, so we're not doing. It was just a whole bunch of stuff that we weren't, as nurses, very satisfied with. We wanted more protection. So when you heard on the news that we were wanting more, but it is true. We wanted more protection because they didn't know, and every day things were changing. So protect us to the max first. It was very staggered.
So in your hospital, it's not that it wasn't enough supplies per se, it was just not the right type of supplies that you were able to get access to.
It wasn't the right type at first. Now that we are in it, this week has been pretty interesting because I have noticed a change of the quantity of things that aren't available to us. Several floors are running out of gowns. For the last several weeks, the managers were locking up the mask because people were taking masks. As information got out, and people were saying you need a mask, masks were walking. So it was pretty much understood. We understood why the managers started locking up all the N95s and, started locking up the surgical masks. And when you needed it, you asked. But then it got to a point where when you asked, it was a little bit sometimes difficult to get what you really needed, and if it's my health versus going into a patient's room to do, my job properly, and you don't give me what I need, as a nurse, that's frustrating, because you want to protect yourself, but you want to help this patient, and you don't go in until you get what you need.
Right. Yeah, I agree, because me and my husband were having that conversation about the change in the notice about the masks, because originally when it started, it was, you don't need a mask unless you're sick. The only people who should be wearing a mask are the people who are sick. But that is not the message that you're receiving now. Now it went to, if you were going into the stores, wear a mask. But if you were out exercising or if you were outside, you didn't really need a mask. Now they're telling everybody everywhere, if you're stepping outside your house, then you need a mask. So yeah. So I was just wondering if the same messages that we were getting as a general public was the same, with the hospital, or if you guys were ahead of the curve since you're dealing directly with the patients. So it sounds like that's not necessarily.
Yeah, we weren't ahead, nor were we far behind, but we were pretty much with. It's just things are changing so fast that they're having to get the information out and make the changes throughout the hospital. And we understand that. I mean, we go into work and we have emails every day of just things that are changing, and we just have to follow suit, And as things are changing, you just have to remember to protect yourself, washing your hands vigorously, with soap and water. And we do that so much in the hospital. So it's just protect yourself. And that's for everyone, not just, the healthcare providers.
Right.
It's everyone.
So the N95 mask versus the surgical mask, is that made out of different material? What's the difference in those two masks?
It's made out of different materials, and the N95 actually has a filter in there. The N95 is more snug fit. It's a much more snug fit. N95 mask you have to get fitted for, actually. And yes, so there's different sizes. You just don't grab an N95 and you put it on and you have an N95. You have to get fitted for it to make sure you have a nice solid fit, So the surgical mask, you have your little, you can stick your fingers, inside of them. It's not like a nice solid fitted mask around your face. The N95s, if you have to wear it all day long, which sometimes we do, it's hot, it's irritating on your face because it's fitting you up on your face. And it's hard to breathe. But again, the flip side of it is you're not protecting yourself. So yes, we had the N95s. On top of the N95, we have our surgical mask, and then we have our face shield that fits over it to protect the mask.
Right.
Right now, we're in a situation where we're having to wear the face mask to protect the mask that we have one underneath it, and we're not disposing those masks. We're wearing those masks continuously. For example, the N95, we're being told to wear them for 3 shifts, which means 3 days, which means, there's a chance of that mask getting contaminated.
Right.
And you wouldn't know per se, but you have this face shield over it to protect it. So we're putting in these masks on, taking them off, putting them somewhere, which is a paper bag with our name on it. And then we come in the next day and we're supposed to wear that mask for that day. Then wear it the next day.
Now, is there a way to disinfect the mask? Or, because I know with the N95, since they're a snugger fit, it's not like you can take that home and toss it in the wash machine, dry it, and then bring it back fresh. So is there a way that you can protect it? Because I know I spray mine down with Lysol. If I go to the supermarket, I spray it down with Lysol inside and out. And then I hang it up to let it dry.
I don't know about Lysol. I don't know if that over time breaks things down, breaks the material down. I don't know. At one of the hospitals that I work at, they use ultraviolet light, the purple light.
Yeah.
I've been told that's how they are sanitizing them. I don't know. I've heard of that before. I don't know too much about that, but I know that that's one way that they are sanitizing it.
Okay.
Yeah. At my other hospital, we're just using it for 3 shifts and then throwing it out. The N95. And then the surgical mask that we're supposed to use also, we're using that until it's soiled or it's breaking apart, basically.
So you're just reusing them.
We're just reusing our own. Yes.
Oh, wow.
Yeah. And also we have that face mask to help protect it, and in between each patient, we are wiping down our face mask.
Wow. Let's see. What was something else that I was going to ask? So how is it being transmitted? Just by someone breathing on you, or do they actually have to cough and spew mucus on you? And is that how it gets transferred?
It's actually quite, as you probably have read, it's pretty aggressive, and it's transmitted very easily. You don't have to, cough up a big loogie, to, and expel it out in front of someone. You can just be talking to someone, because actually, me talking, like if you were in front of me and I'm talking to you, I can actually, spread it by just talking to you. Because when we talk, we're expelling particles that we don't see.
Right.
You've seen people when they're talking, they spit and like, oh, excuse me, So you do have stuff coming out your mouth. That spit that you can see. But when you're talking, you are expelling particles. And in those particles are infected with the virus. So as I'm talking to you, you have to breathe in and out. So you're breathing, I'm talking to you. If I'm positive, COVID-19 positive, and I'm talking to you and I'm spewing out all this infected particles, and you're breathing, because you have to breathe, and I'm talking to you, you're breathing. All it takes is you to breathe it in, and it's up in your nose now. And once it goes up in your nose, we've heard that they like nice, moist, dark, cool environment, which your nose is definitely. You just basically have a very high chance of being positive now. You might not feel it right now, but you just breathed in some contaminated particles. So now it's in your nose. And once it goes into your nose and it starts, doing its process of multiplying, and it goes into your nasal tract, down your trach, that's all that it needs.
Yeah.
Because that's where it's trying to go. It's trying to go into your lungs. That's its goal, to get down to your lungs.
I've heard different people trying to use home remedies. Someone said that if you do the whole humidifier thing where you put your head over a pot, I think somebody used oranges and cinnamon sticks or something other like that.
I've seen some crazy stuff.
Someone else said they use a blow dryer. You spray your face and then you use a blow dryer. And then I know neti pots are supposed to flush it out. To your knowledge, do you know if any of those things work?
I do not. I do not. I wouldn't tell someone to go ahead and do that because it's not proven. I think the mindset is, this virus likes nice, cool areas. And all those things that people are doing, it involves heat, So I think that's what they're thinking. If I get some heat up in there, I can kill this virus.
Right.
I don't know. When you wash your hands and they say wash them for 20 to 30 seconds and with soap and water and hot water and wash your hands and rub it vigorously. that's killing the virus. So I think it's the heat thing that people are focusing on, putting a blow dryer up your nose. I don't know if that's true. I don't know. I do know that good hand washing kills
that works. Yeah, hand washing cures everything.
And I have read and I have heard that the virus, or the front layer, the outer layer of it, is a protein. It's made of a protein. The virus itself, the front layer, and it's a really delicate virus, actually. So that's where they tell you to wash your hands rigorously, just rub, really hard, because it can break that layer up easily, because it's a delicate virus is what I've heard. So, and that's how you kill it.
Okay. That's good to know. Good to know.
Wash your hands.
I said from the very beginning, I was like, if people had better personal hygiene, we wouldn't be in this situation.
I heard that too. And you're right, just wash your hands.
Yes, if people just wash their hands, because I've seen it where people would walk out of the bathroom without washing their hands to use hand sanitizer. Like, why would you walk past good old-fashioned soap and water to use sanitizer? And to me, sanitizer, I know it kills the germs, but in my mind, I just visually see people just rubbing in the germs. Like, if you have something on your hands and then you use the hand sanitizer, I'm thinking, aren't you just rubbing it in? Like, you're not getting rid of it. There's nothing to rinse it off and, refresh it. You're just kind of rubbing it into your own hands, right?
It's the it's the alcohol in it that's supposed to be killing whatever's on your hands.
Right.
But even with using hand sanitizer, after you use hand sanitizer, you still feel a residue on your hands. Yeah. And that's just me. I need to wash my hands eventually. Yeah. So even though you use hand sanitizer, when you get to a place, your home or some place where you can wash your hands, just wash your hands with soap and water, And even in the hospital, we know they teach us, after so many, hand sanitizing that you do, you have to wash your hands, So it's both.
Yeah, that's crazy.
You'd be surprised at how many people don't wash their hands. It blew my mind that I was talking to a secretary several weeks ago, and it was a group of us sitting here talking, and she's like, well, I don't wash my hands when I urinate. If I do, number two, I wash my hands, but I normally don't wash my hands after I urinate. And we're all looking at her like, and I just said, I gotta go. And I can't have a conversation with you guys right now. But that blew my mind, and that's just one person, but I'm sure that's people's mindset. Urination is really, something simple and clean, and I don't have to do that. But if I do the other thing, I had to wash my hands. But no, your hands are down there, so you have to wash.
Two things. Number one, that's why you can't eat everybody's stuff at the potluck. Number two, that's exactly why this virus is being transmitted, because people ain't washing their hands. People didn't wash their hands. That's nasty. I don't know. I always say, like, I just don't know what runs through people's minds. Or I used to work with a lady who, she would come to the bathroom, she would wash her hands first, go to the bathroom, and then she would leave. You're washing your hands so you don't contaminate yourself, but you're nasty after you go to the bathroom because now you want to contaminate everybody else.
Everybody else, yes. No, wash your hands. Good hand washing.
Yeah. I wanted to ask you another question. Another topic came to my mind is there's a lot of reports about the treatment of African Americans in the healthcare industry. I know I spoke to another nurse offline before, and she gave an example of, I guess every so often you have to go through some sort of a training class. And she was saying that sometimes she didn't use the word racism, but sometimes she was saying that there are practices, I guess, that are embedded in you, and sometimes you don't even realize it. But the exercise was, they had 20 patients. They gave the name of, they gave their nationalities, they gave their symptoms, and out of the 20 patients, you were only allowed to save, I think, 5 of them. And she was saying that the class that she was in, I can't remember how many students were in her class, but out of the students that was in her class, none of them chose to save the African American patients. They all chose
Wow.
other patients. Yeah.
Wow.
So as you're working in the hospitals that you're working in, do you notice any type of differences in the treatments for African Americans?
No, I don't. No. No. I know that that was news last week that the number of African Americans in Baltimore City that have become positive is way high than the Caucasian race or any other race. You know, the African Americans high. And I believe that, you know, talking to someone in the hospital, that they were contributing that to, you know, African Americans tend to have other things, other health, you know, high blood pressure, you know, the diabetes, you know, we just happen in our race to excel in that area, I guess. I don't want to use the word excel. We just happen to have those comorbidities, you know, more so than another race. So I think with having those comorbidities, I think that sets us up for the numbers to look like, you know, African Americans are getting infected way higher than another race, you know, that we have those other health ailments, you know, that are more prominent than the other race. So it may make the numbers look real high.
But why do you think that is? Do you think as African Americans, we don't go to the doctors to get ourselves checked out? What do you think is the contributing factor to that?
I think it has to do with that. I also think it has to do with, if you look at, I'm going to throw races out here, but if you look at the African American, the Caucasian, and let's say the Asian, nowadays, you know, things are changing with the outwardly appearance. You know, some of those other races are catching up to the African American, but it's always been, you know, African Americans have always been big, or, you know, overweight, or, you know, voluptuous, and, you know, we're beautiful people, you know. Asians tend to be slimmer, or, you know, I think a lot of that's changing now. You know, I think they're catching up to, you know, there's some big, you know, Asians and big Caucasians, but for a majority, I think the Black or African Americans, we've all been, you know, big boned or whatever. It might have been our diet, you know, the stuff that we eat, you know,
Cornbread.
extra seasoning. Yeah, you know, the extra seasonings we may put in that might have a little bit more sodium in it. And, you know, that helps, you know, the blood pressure issues and, you know, just stuff like that. I think, you know, for the most part, it's just, and, you know, it could be hereditary too, you know, some factors of the hereditary, but I think it's the lifestyle that a lot of African Americans live does not promote good health.
Yeah, I read that somewhere too, where someone was coming from the perspective that some of the issues like the high blood pressure and the diabetes isn't necessarily hereditary, the disease itself, but it's the practices that we pass down to the children and things of that nature. That's what makes it hereditary. The fact that we don't, you know, like you said, that we don't, you know, watch the sodium intake on some of the things that we cook and things of that nature. And that's what could be causing the generations of that disease going down the line.
Yeah. Right. I think I think a lifestyle has a lot to do with it. Not so much hereditary, even though it's that could be some kind of underlying there, but it's lifestyle. I think a lot of things just fall back to lifestyle.
Yeah, I read that before too. Said that. Yeah. Well, I appreciate you. Do you have anything else that you want to share? Do you have any I know I asked before, do you have any myths or crazy remedies that you have heard that you would like to be like, let's just dispel that right now?
Don't put a blow dryer up your nose. um, right now, I can't think of anything. I have read some interesting things and seen some interesting things like online, and I think for the majority, for the most part, just stay protected. Right now, stay inside. Everyone should be staying inside unless it's something essential that you have to do, like go to the grocery store, or if you know you have to go to work and you need some gas, go to the gas station. That's another thing, another way to protect yourself. Um, just stay inside if it's not essential, because us essential workers, that need to go to work to save lives and take care of people who have contributed this virus. It's serious, and people who are just going outside just to go outside and who aren't wearing masks, and you're walking around and you might not feel sick, but now they're saying, even though you don't feel sick and you don't look sick, you can be a carrier. And that's why they're having everyone wear masks now. You don't have to be laying on your deathbed and feeling all hurting and sick to get someone else sick.
Right.
But once you guys are sick, you guys are coming into the hospital where we're having to take care of you. So listen to the recommendations that they're saying. Stay inside. If you have to go outside, wear a mask. If you wear gloves, make sure you're not cross-contaminating, and when you get back home from being outside, just wash your hands real good.
I know since you work in a different unit, you're not necessarily in the emergency area or anything like that, but because I've heard these are the different things that I've heard, if you just have a little cough or a little tickle in your throat, they're telling you not to stay home because, the emergency ward is overflowing with people. But when should you go? Should I wait? I feel like, if I wait too long, then I'm far along. And then it's like, well, it's like, you might as well just go ahead and stay home because it's already progressed to this point. So what's a good rule of thumb, or what's a good way to determine if I should actually call my doctor or go to the emergency?
All right. So let me backtrack a little bit. It's not so much that the ED, the emergency departments, are overflowing.
Mm-hmm.
What we don't want is for you to come in because you're not feeling well and you are possibly positive, and then you walk the ED where there's other people around, and now you just spread the virus with these 10 or 20 or 30 people there. And then that's what it's containment. Mm-hmm. So that's why they say don't go to the ED, or don't go to the urgent care, or don't go to your doctor's office, because if you are positive, you can spread it that way. So that's why they say go home, stay home, self-quarantine yourself, even if you have other people in the house. Just stay away from them. If you pick a spot in the house, that's your living space for the duration of your illness. You're going to go through the coughing, the hurting. I've heard that, people have complained about it hurts to breathe, it hurts to cough, the high fevers, which we all know once your temperature gets over 100, you don't feel good. I've heard temperatures of 102, 103. You're going to get febrile, you're going to have a fever, you're going to have the body aches, you're going to want to stay in bed. I've also heard move around as much as you can, because that's what the virus wants you to do, is just lay there. All that. But once you start having some breathing issues, once you are, your nose might have some mucus in it, you're able to clear it out, you're fine. But once you start getting short of breath, once the breathing is involved, that's the time to start heading to the hospital. Put a mask on, go to the ED, or call your doctor, say this is what's going on, boom, boom, boom. And if you say, your breathing is starting to become hard, they'll probably tell you to go to the hospital. So that's the time to go to the hospital, is when you can tell that you're getting a little bit, your breathing is getting involved, because more than likely you need some oxygen.
Okay.
And hopefully, I was just talking to another nurse yesterday when I was at work, and I was like, I'm not scared of this. I'm not scared of this. I'm concerned about everything, but it doesn't scare me. The one thing that, if I was to say I was a little scared of, I'm not scared of the virus. I'm scared of becoming positive, going into respiratory distress, and having to get intubated.
Okay.
That's what I'm scared of, because, and she agreed, we both agreed. And if your breathing gets that bad and you have to get intubated, you have to get intubated, because then the ventilator takes over your breathing, so to rest your lungs and have your body fight. But, some patients who are intubated, some aren't making it. Some are having a hard time getting off the vent once you're on it. And then other people, recover, get extubated, which means to take the breathing tube out, and they're okay, But I think that's the one thing that is disturbing to me when it comes to me personally. I don't want to go to the point where I have to get intubated.
And intubated just means the tube goes down your throat, right? The breathing tube.
The tube goes down into your lungs. Yeah. And then basically the ventilator is taking over your breathing at that point.
Wow. The thing that I hear, when you read about cases, the thing that makes me most afraid is that once you are diagnosed with it and then you get hospitalized, you're by yourself, right? Because they don't allow your family to come into the room with you. And then because the risk of being infected is not even like they can be outside of the room to look at you or to talk to you, from a distance, because they don't want you to be exposed. So you have to be at home. So there's nobody there with you except for of course, the hospital staff. So that's the part that kind of has me shook. Like I couldn't imagine going through that and not being able to have my husband there with me, or being able to talk to my mom, see my mom, or whatever sibling would want to come to be with me. They couldn't. There's no way for them to do that.
And that is that's hard, because we in hospitals all around, you can't even get past the front door if you are a visitor. You have to have your badge to get scanned in at the hospitals I work at. So there, you're not a visitor just walking up and then you're like, you're upstairs in the units. No. So no visitors are allowed in hospitals. And yes, the patients are by themselves. And, it's hurtful to me, because, that, my heart goes out to them, because they're sick. They know what they have, or they know what they're being ruled out for. They know they can't have any visitors. They can talk on the phone, but that's a little different. Sometimes you got to have your family face to face, and they don't have that.
Right.
Once they recover and they're on the upswing of things, and they're, they get tested and they come back negative 2 times, which means they're not infectious anymore. Then they can have, they're basically going to get discharged at that point. But they're there with the healthcare, the nurses and the doctors fighting this fight by themselves, and that's frustrating too for a nurse too, because they know that. And as long as as much as you want to stay in that room and be with them,
you got work to do. You're at work.
You got work to do, but your goal is to get in and get out of that room too.
And the other aspect of that too that I think about is, not only is your family not there, so once you're intubated, it's not like you can talk, right? The ventilator is breathing for you. So then how are medical decisions being made? Now someone has to get your family, your loved one on the phone to make a decision, but what if it's an emergency situation? They're not gonna call back 3 or 4 times to get somebody on the phone to make that decision, right? So now the decision is left up to the hospital staff.
For the most part, when you go into the hospital, they find out whether or not you have an advance directives or, or that. And it's not really so much left up to the staff. I mean, your significant other or your next of kin is still in very close communication with the staff.
Okay.
The doctors are in communication with the family members. So, there's that talk. And hopefully, before it gets to the point where it's a critical condition, they may have had that opportunity to talk about that. You have a patient in the patient hospital bed, they're starting to breathe a little heavy. The doctors are in there talking to them before it gets to that point where they can't make decisions. Once you have a patient who is not looking really good, that is part of the conversation. If you want to be intubated, are you okay with being intubated? If we have to intubate you to take control of your breathing, if you poop out, blah, blah, blah. That is a conversation that the doctors are actively having with the patient if they're getting to that point. So while they're in their right mind, while they're able to answer questions, while they're able to, make decisions for themselves, they can answer that question. Yes, intubate me, Yeah.
Yeah. So those are the things that scare me. So when I'm thinking about, getting my mask to go to the supermarket, like you said, actually getting the virus isn't necessarily what's in my mind. It's that vision that I have of being by myself in a hospital room and not being able to be in contact with my family. That's what I'm thinking about when I'm like, maybe I need to maybe I don't need those chips, or maybe I don't need that milk. I'll drink some water with this cereal today. That's the kind
don't need that donut.
That's the kind of stuff that's like running through my head.
Yeah, that can help some control. That can help you. That can make you have some control. But it's sad. It's sad. It's sad. But on the flip side, I just pray, and this is a wake-up call. This is a call for people to do good hand hygiene or have good hygiene, period. But also to check yourselves in your relationship with your creator. He doesn't just have the United States attention.
Yes.
God has the world's attention. He has the world's attention because it has touched the world. It hasn't just touched the United States. It hasn't just touched China. It's touched the whole global in which he has created. And everyone attention is, he has everyone's attention.
Yep.
People who haven't prayed in a long time, they're praying now.
Yes, they're getting reacquainted.
People are asking him, heal the land. Yeah.
Yeah.
Yeah. So he has everyone's attention, and there's a reason, there's a purpose for all things. And, people just need to remember those things, but also this is his world. Mm-hmm. We're living in it, so he's just bringing things in alignment of how things should be, and if he has to allow things to take place, not as a curse or not as he's allowing things to take place for a reason, and it's for his purpose.
Yeah, I hear you, Pastor Johnson. All right.
It's all for his purpose. So we just need to do things that are recommended, from the people that he has put into those places. Right. Follow them, pray, and we're going to get through this. Yeah. We're going to get through this.
It's interesting that you say that, because I have seen so many debates about that. Some people are like you said, have your mindset where it's like, all right, I got to make sure I'm following the rules, staying prayed up. But other people have been like, well, if you are a person of faith, then you should not be concerned about, wearing face masks because, you're anointed and, touch not my anointed. When I hear that, that drives me crazy. It drives me crazy because I feel like God is giving you wisdom. Like I said, you said it, where he's giving you wisdom. And what makes you think that the people that he has put in place to give you that information is not a directive from him? You know what I mean? Like, they're not being used to tell you to put your face mask. Because I look at it like this. If you lock your doors at night, if you have an alarm on your home, if you have an alarm on your car and you use it, what's wrong with using a face mask when you go out in public?
Yeah.
Like, I'm just
another protection. Like you said, God gave us wisdom. He gave us common sense.
Yes.
So if something is trying to get into your body that goes up into your nose or your mouth, then you want to cover it. That's common sense.
Yeah, exactly. Absolutely. So, yeah. So I have two more questions for you. And these questions are things that I ask all of my guests. So the first one is, if you have money, if money and time were limitless, what would you do?
If money or time was limitless.
Mm-hmm.
I would most definitely make sure my family is set. I'll make sure mom is set. Make sure family's set. Extended on from that, I am part of, in my church, I'm part of homeless ministry. So I'll probably do something for the homeless. I would do something for the homeless, whether it's to help support the shelters, create a shelter that's not so limited in time, like they have to leave in the morning and come back after, just maybe establishing homes for them. All these buildings downtown Baltimore, which are abandoned and caving in and everything, why not build them up and have homes for homeless? And then do some education there, and then maybe create some jobs for the homeless. So now they have a home, they have an address. So now they can put an address on the application, because if you don't have an address, I've been told that you can't work or something. I don't know. So they have an address, do some education, get them some jobs, and just help the homeless. I'll probably donate to some animal shelters, because there's a lot of animals out there, unfortunately, that are running around in Baltimore. Maybe do something for them. So I'll probably family, homeless, animals, travel. Yeah, I'll probably travel, but I wouldn't travel nowadays. But outside of COVID-19, probably travel, take my children to different places that they haven't been to.
When someone asks about you, what would you like them to say?
That Alecia has a caring heart. She's sensitive. She's dependable. Someone that they can count on. She has a heart to be nurturing. Yeah, I could probably fill in a couple other things, but they may not be, But yeah.
How many nurses do you have in your unit?
In my full-time position that I work, there are 11 of us, not all together. There's different shifts, but it's a small unit. So there's 11 of us vascular nurses.
Okay.
Vascular Access Nurses.
So what I would like to do, I appreciate you for being a guest here with Bumping Up My Gums, but we
Thank you.
also appreciate you and your fellow nurses for being on the front line and dealing with the patients. And no matter how crazy things get, you're always called to be there. So we really do appreciate you. I would like to send you $100, and maybe you can treat the nurses to lunch or something, just as a thank you. And we appreciate you for all that you guys are doing. So.
Oh, that is nice. I sure will. Pizza, donuts, you know.
Something, like I said, just to say thank you from Bumping My Gums, like I said, for you being there. And for some of your patients, like we just discussed, your staff is probably the only people that they see and have contact with in the outside world. So we appreciate what you're doing. And just text me your Cash App, or if you don't have Cash App, maybe I'll send it to you via PayPal or something.
Okay.
But yeah,
We can do Cash App, and I would most definitely share this with them and let them know who it's from, and check up her YouTube station, and you know.
Absolutely. Yes, please do that. Thanks for watching, Gummies. I really appreciate you tuning in. Have a great day on.
Thank you.